welcome everyone. Thanks so much for joining In the Hot Seat, a live Q&A on all things retina, brought to you exclusively by Apellis. This is your time to ask anything that's on your mind, hopefully retina related, but I'll take whatever you guys have questions about. Just drop your questions in the group chat during this session, and I'll try to do my best to get to all those questions. We also had some fantastic questions come in ahead of time and some left over from the last hot seat session that I'm going to answer here as well. So we'll get a mix of some of the older questions from the first session and anything that you guys want to put in the chat box here now. And let's go ahead and get started and keep those questions coming in. Thank you again for Apellis for sponsoring this hot seat Q&A session. So there was a question from Shari that came in during the last Q&A takeover. What is the risk of worsening background diabetic retinopathy in patients that have just a few peripheral hemorrhages? And so I wanted to share this graphic here and some literature research that would suggest that patients that have predominantly peripheral retinopathy, where most of the hemorrhaging and microaneurysms are out in the periphery of the retina, which is best detected with either BIO examination or ultra-wide field color fundus photography, have an increased risk of progression to proliferative disease compared to individuals where the majority of the hemorrhaging is just in the posterior pole. And so for me, the clinical take-home of this is I do ultra-wide field imaging on almost all patients that have diabetic retinopathy. If the majority of that imaging or the hemorrhaging is out in the periphery, I'm going to monitor them a little bit more closely as opposed to somebody that doesn't have that many peripheral hemorrhages. And so it's hard to say what is the exact percent risk of them progressing, but it is definitely something that you say, oh, I'm going to monitor this patient a little bit more closely because I know it's a risk factor. I think also coming into play here with regards to how can we determine which patients are at risk of converting to, say, proliferative diabetic retinopathy would be ERG testing as well, I think is another thing that helps give us some perspective on what is this patient's risk of going on to develop proliferative disease? How closely do I need to monitor them in terms of frequency? So thank you so much for that question. Another question that came from the last Q&A that didn't have time to get to, it was a question with regards to neovascularization on the iris. How can you differentiate between normal iris vessels from iris neovascularization? And so I wanted to pull up some graphics here because I think this is a really hard thing to describe without sort of a graphical presentation. But patients with iris neovascularization, it often starts on the pupillary margin, although in about 10% of patients, it may actually start in the angle itself. But it almost looks like in the early phases, I like to think of like a dusting of like red paprika or something on the pupillary margin. So these like fine little like nubbins or dots of redness on the pupillary surface is usually really early iris neovascularization. When it's more extensive, you may actually see some pretty well-formed mature vessels on the surface. When it comes to doing gonioscopy to visualize like iris and angle neovascularization, those blood vessels tend to grow upward initially and cross the scleral spur and then proliferate along the pigmented trabecular mesh. We're kind of giving it like a reddish hue type of appearance. And let's compare this with patients that have, say, just normal iris vasculature. So you're looking at a patient maybe with like a light blue iridescent iris, and you're seeing something like this in the angle where it's a more substantial, like larger caliber vessel. See how it also follows the orientation of the angle kind of across there is more characteristic of like a normal blood vessel appearance. Also, on the right-hand side of the slide here, we have like a normal radial blood vessel of the iris, and this isn't neovascularization. That's just a normal presentation for this particular patient. But I thought that was an excellent question and something, in academia, I see students kind of struggle with a lot in residents alike. So thank you very much for that question. Another question that came in from the email kind of blast was, let me read the question here. I have seen lately a small flat nevus that's very slow growing over time over the past 8 to 10 years. Very benign in appearance. Without a prior photo, I would have never referred. any comment on this. And so I think anytime you're seeing growth of a pigmented choroidal tumor, I will definitely myself refer that for a second opinion, whether it be a retina specialist, perhaps that's most appropriate, versus say directly to an ocular oncologist. But I would also make sure you're complementing your retinal photos, which is, a great way to monitor for change over time with other multimodal imaging technologies. And so things like are included on this slide here: fundus autofluorescence, ultra wide field color fundus photography, as well as like B-scan ultrasound and OCT can be really valuable to say, are there other risk factors present here that potentially I'm missing that would make this, even more high risk than just the growth alone? Also, I think you not only measuring from, your photo, what is the diameter of the pigmented choroidal tumor, but also trying to measure the anterior posterior thickness in some way, whether that be B-scan ultrasound or whether that be like enhanced depth imaging OCT. If you're seeing that thing get bigger anterior posterior thickness over time, as well as getting larger in diameter, certainly that is I think, a concerning feature that should be referred to a specialist for consideration of therapy. And so I want to give some examples if we're trying to assess the anterior posterior thickness, which is an important measure to get on patients with these pigmented choroidal tumors. On ultrasound, your cutoff for suspicion is about 2 millimeters anterior posterior, whereas if you're using OCT, it's about half that. Because with OCT, we're using light waves instead of ultrasound, which is using sound waves. And so on OCT, it's going to be closer to like 1 millimeter should be your cutoff for, this is potentially suspicious. But certainly monitoring for progression over time is very, very important. Leveraging your wide field, ultra wide field imaging to assess these changes over time. And like you had, mentioned in this question in the email, how valuable it is to have a photo of a lesion to look back to say, has it changed over time? And so a lot of these tumors that are like out in the mid-periphery and the periphery, it's going to be really hard for you to assess if all you have is a description or say a hand fundus drawing of this particular lesion. So get photos, use the caliper tools to measure the longest diameter. Wide field fundus autofluorescence is also really valuable to assess these more like peripherally located pigmented tumors. And the value of fundus autofluorescence, right, is to assess for lipofuscin deposition that could be subtle on clinical examination. And so lipofuscin deposition is usually going to be very like bright kind of white intensity on fundus autofluorescence because it's naturally fluorescent. And that's a high risk factor for melanoma. Any patient, and this was a patient of mine right here, that otherwise the tumor looked pretty benign, but then my FAF is showing me clearly there's orange pigment. I can see the orange pigment when I look back now at the color fundus photograph. That's a patient I referred to retina because that's a particularly high risk feature for melanoma. And of course, B-scan is valuable in assessing the anterior posterior thickness. It's also valuable in saying, is the tumor internally dark or acoustically hollow, we call it, which is another risk factor for melanoma development. And then I included this graph here that is from one of Carol Shield's studies that shows like how you can sort of customize your patient's risk based on how many risk factors that they have. And what I want to draw your attention to is over on the left-hand side here, not all risk factors are created equal, right? So you'll see orange pigment alone, just that one factor, like think about this patient we were just talking about, has a 37% risk of growth over the next 5 years' time. So there's so much value in doing fundus autofluorescence in addition to, say, color fundus photography in patients with pigmented choroidal tumors. Other things that are high risk would be, say, fluid, especially like subretinal fluid, overlying tumors as well. But thank you for that question. Let me see what else came in here. Great, there's again some great questions in here. What's your opinion about meiotic drops for the management of presbyopia? I think they are very valuable, and I'm very close to the point where I'm going to be needing them myself. By way of disclosures, I am a paid consultant and advisory board member for Lens Therapeutics that makes Viz. So I'm excited that potentially we have an option that may be more beneficial in terms of or let me say, have a lower side effect profile from a retina perspective compared to some of the older, stronger miotic medications. But I do think, post-marketing here, as it hits the masses, we're going to see, is there going to be any sort of retinal complications or not? But in theory, hopefully there'll be less. But yeah, I mean, I think it's an exciting time. Another question that came in earlier, does anti-VEGF injections, excuse me, do anti-VEGF injections help to prevent dry AMD worsening? And I think Dr. Modi covered this a little bit in the last presentation, but it's worth mentioning again. And I'm going to kind of divide this question into twofold, right? So we have like intermediate non-exudative, non-neovascular AMD. And then we have patients that are kind of in this category of having non-exudative choroidal neovascular membranes. And so I think when we have patients in either bucket, anti-VEGF is not appropriate. However, I have seen or heard of some retina specialists treating non-exudative choroidal neovascularization with anti-VEGF and assessing the endpoint as being shrinkage of that membrane on OCT angiography. But that's definitely not commonly done. When it comes to just say like intermediate stage, non-exudative, non-neovascular AMD, there's no indication for anti-VEGF injections here. What I would do instead is certainly like monitor that patient more frequently, doing imaging. You're trying to catch the earliest conversion to exudative AMD. Home self-screening is going to be really important, AREDS2 supplements, and potentially photobiomodulation for patients that kind of fall into this bucket. When it comes to patients with these non-exudative choroidal neovascular membranes, and let me pause for just a moment and explain what this was in case nobody saw somebody didn't see the last lecture with Dr. Modi. When you have a sub-RPE or like a cult choroidal neovascular membrane that doesn't have fluid on OCT, doesn't have hemorrhage on clinical examination or any exudate, how are we to manage these patients? We know that they're at increased risk of converting to exudative AMD, so certainly monitoring them more closely. Like this is a patient I would usually watch at least 3-month intervals, and this particular patient did end up converting to exudative AMD. So monitoring them more closely. But the clinical trials that looked at, should we treat this with anti-VEGF therapy? And those particular trials, I put down here at the bottom of the slide, the PROCON and the PREVENT trials that Dr. Modi had discussed, where they're doing anti-VEGF quarterly to see, was there any reduction in the risk of converting to exudative AMD? And they found that there wasn't any benefit. And kind of note, to piggyback off of that, could it be harmful? We think that, anti-VEGF therapy can sometimes cause side effects of RPE atrophy or like geographic atrophy. Whereas these membranes, actually non-exudative choroidal neovascularization, may serve some sort of purpose in helping preserve the RPE. So they're actually protective against geographic atrophy development. And so, I think the answer here is anti-VEGF therapy of non-exudative choroidal neovascular membranes is not indicated, and there's not evidence to support its use, although I do know like a handful of retina specialists that may be treating them despite that. Please remember, if you have any additional questions, please put them in the chat. Otherwise, I will continue through the list I had from before. There were several questions on OCT angiography, which I'm super excited about because my session on OCT angiography is coming up here shortly. One question was, in today's modern optometry practice, how critical is OCT angiography, considering that we may typically refer these retinal cases to ophthalmology? And I would argue very critical. And so OCT angiography has allowed me to detect the earliest neovascularization possible, whether it's in patients with macular degeneration, like this case here, or we were talking about these non-exudative choroidal neovascular membranes. We can find the neo before it actually leaks out fluid with this technology. And then knowing that they're at high risk of exudative conversion, we can monitor them more closely and catch them as soon as they convert, start treating them, and preserve good vision in macular degeneration. And then for me too, I think for diabetic retinopathy, detecting the earliest proliferative retinopathy has also been a huge clinical application. that there are so many things I would have missed. And I humbly say this on my clinical examination, had I not had imaging to kind of back me up, especially OCT angiography. So OCT angiography, we know, provides this really high microvascular resolution of the retina. And so it's going to highlight these subtle abnormal features like IRMA, or intraretinal microvascular abnormalities, retinal non-perfusion, potentially neovascularization, right? And case in point, like this patient I saw, clinically looked at them, they have, intraretinal hemorrhaging in all four quadrants. It looks like there's probably some IRMA present, some cotton wool spots, some exudate, but there's nothing that screams to me that there's neovascularization on the disc or neovascularization elsewhere. There's no preretinal or vitreous hemorrhage. So I'm thinking, just based on the clinical exam, right, that this patient has severe or very severe non-proliferative diabetic retinopathy. And yet, when we look at the OCT angiography, this is the superficial capillary plexus preset. We can see there's a lot of non-perfusion present, which is kind of to be expected in this case. But when we look at the vitreous or vitreoretinal interface preset, this patient actually has the teeny tiny area of neovascularization in the inferior temporal arcade that I personally missed on my clinical examination. I would have called this patient severe non-proliferative when in actuality, they are low risk proliferative. And so OCT angiography affords us the opportunity to definitively differentiate, right, between IRMA, intraretinal microvascular abnormalities, which is a feature of NPDR, versus neovascularization elsewhere, which is a feature of proliferative diabetic retinopathy. And so in this patient, all I've done is just blow up this like little area in the inferior temporal arcade. So you can appreciate that neovascularization in diabetes is preretinal, meaning it's growing like up outside the retina. And so we can capture that when we isolate blood flow of the vitreous, which is this vitreoretinal interface. And so I would argue that OCT angiography will allow you to detect the earliest neovascularization in both AMD and diabetic retinopathy. And I feel like this is not like an isolated patient. This happens to me like almost on a weekly basis, unfortunately. But these are patients that if they're proliferative, they need to go to retina, and most of these patients have gotten PRP as a result. I think another advantage of OCT angiography and why it's so critical in our clinical practice is, again, like missing what is like invisible, right, on clinical examination. This was a patient that had type 1 diabetes, and you can see these massive areas of retinal non-perfusion that we can't visualize clinically. So highlighting areas non-perfusion is very important, application of OCT angiography, and non-perfusion in the macular region. So patients that have macular ischemia, right? Macular ischemia, we can't visualize with clinical exam. We can't visualize with just structural macular cube OCT. We have to do some form of angiography to look for macular ischemia, which may limit a visual prognosis for a patient in patients that have diabetic retinopathy or retinal venous occlusive disease. And so I think it's also very critical in terms of your assessment for macular ischemia as well. Another question about OCT angiography that came in said, hello, sorry, I'm not from America. I would like to clarify whether you use fluorescein angiography in your clinical practice. I practice at the Oklahoma College of Optometry in Tahlequah, Oklahoma. In Oklahoma, we can do IV fluorescein angiography. However, I do not, because I have OCT angiography and other imaging tools. I can pretty much get a good sense of, any sort of inflammation I would need with IV fluorescein angiography from that technology. But of course, there's still a lot of retina specialists who love, and their workhorse is really IV fluorescein angiography. And I think probably still the benefit of IV fluorescein angiography over OCT angiography is the field of view. You can get really nice, like ultra wide field IV fluorescein angiography. The time frame of getting that and not having to do like montage imaging is also really nice. And assessing like the true activity of neovascular membranes, how much are they leaking? Because there's actually dye injection required with IV fluorescein angiography. There's definitely still value in it. But I personally, handle, and I'm in like retina clinics, diabetes clinics. I mean, I'm seeing a ton of diabetic and retinal pathology. I feel very comfortable with the technology I have and not doing fluorescein angiography, even though I could do so. There's a question, how often in practice is there a need given the availability of OCT angiography. Oh, yeah, I think I kind of mentioned that in my answer here as well. Oh, there's a question that came in the chat from Dr. Wen. Can you please go over the high milligram of zinc in AREDS2, whether it worsens geographic atrophy? I'm trying to remember what the conversation was we were having earlier, specifically about GA, but I think in general, a lower zinc dosage is beneficial for patients in AREDS2 supplements. So the original AREDS formulation has 80 milligrams, but you can get it in other avenues with either 40 milligrams of zinc or 25 milligrams of zinc. If you could get one of those, I think that's preferred because it would decrease the risk of like GI potential complications. And I think patients just tolerate it better with a lower level of zinc, and you still get the same benefits based on the data that came out of the AREDS2 study. Question from Dr. Mina, what is your protocol for seeing a single peripheral heme in an otherwise healthy individual? I think it depends on, can I access the patient record or not? I'm very like spoiled in a setting where I am in like a hospital, like IHS type of facility. I can go back and then look at the patient's blood work, look at their medications, and look at their medical history. So if there's nothing in the medical history to explain it, I'm going to go look at the patient's most recent blood work. So hopefully they have like a CBC with differential. And I was specifically looking at like the hemoglobin levels to see, are they maybe borderline anemic? That could maybe explain the peripheral hemorrhage. I'm looking to see if they have like a complete metabolic profile or an A1C on their chart to see is there potentially they have pre-diabetes. I may also look at their medications. So are they taking some sort of blood thinner like warfarin, Plavix, etc., that maybe could explain it. In terms of patient history, I would also ask the patient any recent Valsalva maneuver or trauma that could potentially explain the hemorrhage. Think what else here? If I don't have access to recent labs, then those are things I would typically order myself. Certainly checking the blood pressure is important, but usually high blood pressure is going to cause more like flame-shaped hemorrhages than like dot blot hemorrhages out in the periphery. So it's kind of like lower down on my list of thoughts. But I mean, I think doing your due diligence of kind of screening for all vasculopathic causes would be important. Asking the patient about symptoms of sleep apnea would probably also be appropriate when we're thinking about retinopathy. And then, I love that anytime you see like a retinal hemorrhage, look at the retinal vasculature. And kind of like case in point here on the slide I was on, right? If you have a patient that has, if it's just hypertensive retinopathy, you're going to see other features before you get retinal hemorrhaging, like attenuation of the arteries, reduction of the AV ratio, AV nicking, right? If it's a patient that has maybe like a really subtle early vein occlusion, you may see these dilated tortuous veins, which are a hallmark feature of retinal venous occlusive disease. If it's a patient that you're concerned may have early ocular ischemic syndrome, and I typically would not order like a carotid Doppler based off of just one peripheral hemorrhage in one eye. But if there were other features maybe present where you could see that the IOP in that eye was lower, suggesting that there's decreased perfusion to the ciliary body, perhaps from carotid stenosis on that same side, or severe arterial attenuation in that eye compared to the other eye. Then that may prompt me, or cell and flare in the anterior chamber, and that may prompt me to order a carotid Doppler, but just the retina finding alone typically would not. Yeah, recommending a brand for the AREDS2 with the lower level of zinc. I'm going to have to get back to you on that, and I will do that. I don't know one offhand, but I hear it's available through Amazon. There was a question that came in earlier about Dr. Malik asked, what's the go-to protocol for central serous chororetinopathy treatment? And what's my take on topical NSAID usage in active central serous? So most central serous resolves on its own, which is great. You can sort of foretell the future and tell the patient it's probably going to get better on its own, and it does. So about like 90% of cases are going to resolve within 6 months of you doing nothing, which is great. but it is your job to rule out, is there a choroidal neovascular membrane present? And so a great way to do that is if you have OCT angiography, go ahead and do that. Asking them questions about risk factors, right? Like pregnancy, testosterone supplementation, any sort of steroid use that could have precipitated it. I often ask patients too about like obstructive sleep apnea. I ask them about like what sort of work they do. Are they on like work shifts? So patients that are like airline attendants or they, work nights are more likely to suffer from central serous, although there's not nothing you can do about that because you got to work, but trying to address as many risk factors as you possibly can and trying to get it to resolve on its own. So while you're waiting, right? So I wouldn't refer a patient to retina until the fluid has been there like at least 3 months, in which case, and there hasn't been improvement and it's looking like the fluid's just hanging out there, right? That fluid could potentially cause photoreceptor atrophy and RPE scarring. So you don't want to leave subretinal fluid hanging out for, 6 months on end. So I usually wait 3 months. If there's still fluid, then I would refer to retina for consideration of treatment. In that 3 month time frame, I have put patients on topical NSAID therapies. And so both bromfenac as well as nefenac have been clinically trialed, and it's not large scale studies. So I think there's lacking evidence to support its use. I haven't seen a patient where I felt like it worked yet. But then I do know other retina specialists who are trying it too. I think it doesn't hurt as long as you're not using it so long that it compromises like the corneal integrity or causes like significant SPK. So typically like a period of using it for, 4 to 5 weeks, I think would be most appropriate. I think there's no harm in trying it. If it fails, it fails and no harm done, right? Other things I would think about too, and I discuss with patients, I ask them if they're already taking melatonin. If they're not, I typically do recommend that they consider trying it. I think there's some decent case reports out there that may support it. I personally do not prescribe like spironolactone or other mineralocorticoids or whatever for central serous chororetinopathy just because there's a lot of side effects associated with them. But again, that's maybe a potential sort of off-label option would be doing like spironolactone or eplerenone. If a patient does need to go to retina, some other therapies that could be considered, micropulse laser photocoagulation is a common one. Photodynamic therapy is a common therapy that tends to work really well. Macular photocoagulation can all be of benefit for these patients. And if the OCT angiography or fluorescein angiography shows that there is a choroidal neovascular membrane present, then potentially anti-VEGF therapy may be instituted in these patients. And that's usually in chronic central serous chororetinopathy. Oh, have I tried? There's a question from Dr. Harris. Have you tried topical CAI for central serous chororetinopathy? I personally have not, but it's something I'm going to go read up on now. I mean, I guess it doesn't hurt to try. I do use like dorzolamide in patients that have cystoid macular edema secondary to like retinitis pigmentosa or other inherited retinal diseases, though, yes. A question from Julia, do you have a different protocol for monitoring diabetic retinopathy in the pediatric population? So diabetic retinopathy during puberty, like puberty is a risk factor for retinopathy progression. So certainly during those years, you should be monitoring patients more closely, especially if there's pre-existing diabetic retinopathy as they're going into puberty. Certainly that's a patient you want to monitor very closely because there's a risk factor during that time. Let me see. There was a question from the last session from Dr. Mehta that said a small cohort study stated that high-dose statins, 80 milligrams, can reduce geographic atrophy. What are your thoughts on this? I tried to look this up during the break and I couldn't find this particular study. I don't know any retina specialists that are prescribing statins specifically for geographic atrophy, so I don't think it's common practice at this time. But certainly, I mean, something interesting to consider, right? How statins are going to help with the cardiovascular risk profile. in general, and we know that that's associated with macular degeneration and geographic atrophy. So the theory behind it seems reasonable for sure. There was a question about, would you recommend AREDS2 vitamins to a young pilot to maintain the health of his or her eyes because of their career, not because of ocular pathology? And I pulled up this study here. I would consider it, so this is more along the lines now of like sports vision sort of performance. And certainly I think antioxidant supplementation, not necessarily AREDS2, I think there are a lot of different formulations out there, could potentially be beneficial for patients either in like high professional sports activities or need very acute good vision, say like a pilot, for flying, etc., or those who need good dim illumination setting, visual acuity or visual function is definitely something that I would consider, not necessarily AREDS2, but maybe some other supplement I think would be very appropriate. And with that, I think that's all the time that we have for this hot seat Q&A session. Thank you guys so much for putting in your questions. I think we had some excellent discussion. And I want to thank Apellis again for sponsoring this hot seat Q&A session. I'll see you guys in the CE track.